It's nice to be here tonight. It's an honor to be part of the American College of Physicians. One of my roles is being a district president for the ACP, which is a phenomenal organization. And I'll get right to it. We only have 15 minutes, and I don't want to take up any of the time with waste. So let's get to multiple small feedings of the mind. And we often take things for granted. And one of the things we take for granted are internists. And internists are the backbone of the medical system in the United States. And you don't need to be an infectious disease physician to do a lot of the things that we're going to be talking about in the few minutes that I have tonight. But we really need to understand that internists drive the engine that is American medical care. And I can't thank all of you enough, both as an internist as well as a subspecialist, that we have such a collegial relationship with all of the internists at our hospital and with the subspecialists in medicine as well as outside of medicine. So it certainly has been a very, very busy year, a hectic year, I would say a hectic couple of years. And for those that have been practicing for a while, as I have, this is certainly the busiest time in my career in terms of all of the multiple infectious issues that we have to deal with. So tonight is not going to be a COVID talk, but we're going to talk about a number of issues, very brief lightning round type of talk to make sure everybody's updated as best as possible as they can be in a very short talk about what you need to know to practice medicine in 2023. So we're going to talk about 6 illnesses real quickly: COVID, influenza, RSV, measles, polio, and Ebola. All of these have been hot in the press for certainly the last half year, if not longer. And we'll try to update everybody very briefly on what's going on with them. And as I said, it'll be the lightning round. So will COVID ever end? And the answer is, I don't think so. I don't think we're going to see an end to COVID. And the new big thing is XBB. And I do expect us to have constantly new strains that will be evolving, some significantly, some less significantly. And each of them will bring its own challenges for the internist as well as for all of medicine. So what exactly are we dealing with here? So XBB 0.1.5 is the current majority strain that we're seeing in our area and is across many parts of the United States. Some different areas of the United States are going to take longer till this strain takes over. But as we've been seeing since Delta, and Delta was around for a while, these new Omicron strains or variants are rapidly changing, and they can have significant differences in terms of the number of these types of strains in different parts of the country, but eventually they're so highly contagious. XBB 0.1.5 is probably the most contagious of all of the Omicron strains that we've seen, which were more contagious than the previous strains. So if you haven't been seeing this, you're going to be seeing this. And that explains why we've seen a blip. There are lots of reasons why we've seen a blip, a bump up in number of cases, but certainly these BA4, BA5, and now the XBB is certainly going to be forcing that increase in incidence. Now, how good is the bivalent vaccine? I think the bivalent vaccine is excellent. I think the bivalent vaccine in the right selected group is going to provide tremendous benefit. And there have been some studies showing, especially in the MMWR about a month ago, that I don't have time to show slides with all this stuff. You'll have to take my word for it or look it up in the MMWR the beginning of December, where they showed clearly that people that have been not having had a booster for more than 8 months and beyond. So people, for example, had their third shot, their booster shot, and it was more than 8 months ago. So then the bivalent vaccines really provided tremendous benefit. They provided less, but still important benefit if you had a booster less than 8 months away. And they provided obviously the least benefit to those that had recently had a booster within 3 months, let's say, of getting their bivalent vaccine. They had an additional booster. But it's important to realize who's currently getting sick. The people that are currently getting sick are the people that have the highest likelihood of, unfortunately, getting serious illness and unfortunately passing away. So while everybody is getting somewhat sick, I should have put in there very sick, the people that are getting very sick are those that are older age. That's number one. The only people that are dying really in the United States right now are people that are above the age of 40, maybe even 50 would be a better answer. Only very, very few people below the age of 40 and very, very few people even below the age of 50 are dying. The people that unfortunately are dying, and thank God at a much, much lower rate than during the 2020 highest points of COVID, where people, unfortunately, in the age group above 75 probably had a 25 to 33% mortality not morbidity, mortality. So those numbers are drastically reduced, thank God. But today, the people that are still dying are those that are unvaccinated in those age groups, or people that have not had the bivalent or at least a third booster, a third dose, a booster dose, at least one. So those people are somewhat more protected than those that have only had two doses rather, and certainly those that never got any vaccine. And obviously, if you've had COVID previously, that's going to add another level of immunity. So I don't want to make this into a COVID talk. I'd be happy to take questions about COVID, but basically, getting a bivalent vaccine makes an awful lot of sense if you're above the age of 50, certainly if you're above the age of 60. And if you haven't had, at this point in time, nobody's had a regular booster probably for 3, 4, 5 months. So it certainly makes sense for that population to get the bivalent booster. Let's move on quickly in the lightning round to influenza. Influenza is certainly well known to every single internist. We've been giving influenza vaccination for years. I've been getting my annual flu shot for many years. The efficacy of this year's vaccine looks to be an excellent match. And while most of this is anecdotal, we have not been seeing patients very sick in our hospital, in the ICUs, and we haven't heard reports of people very sick who've been vaccinated. Now, that doesn't mean that they don't exist. It doesn't mean that people that are at the highest risk at the ends of life are always going to be at high risk of influenza, even if they've been vaccinated. The vaccine's not perfect in preventing illness. The vaccine is very good in preventing illness, and certainly it's very good in preventing serious illness. So I think the efficacy of this year's vaccine being that it's a good match and that everybody's using the quadrivalent vaccines at this point in time, and that we recognize that giving the seniors the senior dose vaccine for those that are above the age of 65. So I think that we are seeing a significant benefit. Now, we had almost no flu last year, almost no flu the year before because of masking, distancing, and all the other things we were doing to prevent COVID spread. So we're seeing, I don't want to say with a vengeance, but we're seeing certainly a resurgence of influenza as people are much more comfortable mixing in indoor settings and not wearing masking or distancing. Who's getting sick? Again, people that haven't been vaccinated and people at the highest risk, meaning those that have underlying significant cardiac and pulmonary conditions, and those older in life, as well as those pregnant and those at younger ages of life. And we've unfortunately seen a handful of deaths in children, which is a shame because this vaccine is very safe and certainly is not a reason not to get vaccinated. Anybody above the age of 6 months of age should be vaccinated for influenza. Next in the triple-demic, as it's called, is RSV. RSV is obviously well known to everybody. I think the most exciting thing about RSV will be next year. But for now, RSV still is an important pathogen, especially in the very young, in premature, as well as young children, and especially in older adults, especially those with underlying comorbid conditions. So I'm not going to talk to you a lot about RSV in either of those groups. Nothing really major new there. I think we're seeing more RSV this year, but we're not necessarily seeing more severe RSV. And one of the reasons it's conjectured as to why we see more RSV is because a lot of the younger children who've not been exposed to RSV in the past, again, because of masking and social distancing, might now be exposed to it. So I don't think there's anything dramatically different about RSV this year, but I do think that we're seeing more cases, certainly in the pediatric population. Fortunately, in New York, we probably have passed our peak, but in other parts of the country, they still haven't reached their peak yet. Big question for RSV is, will there be a vaccine for RSV? And I hope the answer to that will be yes. There are a number of studies that were published at the infectious disease meetings back in October, and they were very promising. And I do hope and expect that there will be an EUA, an emergency use authorization, for some of these vaccines before next year's season. More to come about that, but I think that's especially a welcome news. And vaccination is the theme of a lot of the infectious diseases that we're talking about tonight in terms of preventing them, because the treatments for all of these are less than stellar. And again, who's currently getting sick? In the younger populations, the very young are obviously at risk. 2, 3, 4-year-olds are all getting it at the same time. Older children, obviously there's some illness, usually not as severe, and again, in older adults with underlying medical conditions. Let's move on to measles. And I say this is very sad because we shouldn't be having a talk about measles in the United States in the year 2023. We should be well on our way to eradicating measles across the world, which unfortunately has been stalled because of COVID. And one of the tragedies of COVID, separate from COVID itself is the fact that so many vaccinations across the world, estimated 50 million doses, have not been given out because of the COVID pandemic issues that prevented people from getting their vaccines, even if they wished to take them. And right now, in the United States, in Columbus, Ohio, I want to present to you what this is from the latest data. You can see as of Tuesday, January 10th at 8:46 a.m. was when I looked this up to put it in there. And again, the critical thing here is that this is an outbreak in November of 2022. There should be 0 cases of polio. We have wonderful, safe vaccine to prevent measles. I said polio. We'll talk about polio in a second, to prevent measles. And measles can be a fatal disease. We unfortunately saw in an outbreak pre-COVID 3 deaths from measles in the United States. And this is a serious potential problem, forgetting all of the other complications that measles can cause besides death. So right now, in November 2022, in Columbus, Ohio, we had 82 cases, of which 1/3, 33 of them, more than 1/3, required hospitalization. And again, who's getting this? So of these 82 cases, we didn't know the vaccine status in 3. So you're really dealing with 79 cases. 75 of the 79 had no vaccination, and 4 of them had only 1 vaccine. Not one child who was fully vaccinated got measles. Measles can be a very serious illness. People my age remember what measles was like because many of us had measles, or they knew people that had measles because it wasn't the vaccine yet available, or it wasn't widely distributed. But people of the younger generations don't recognize how serious measles was. And that's a shame because, unfortunately, they're going to find out what measles looks like as we continue to have outbreaks like this. And again, most of these children were probably not going to get measles if they and the kids around them, their siblings, had been vaccinated. So this is a real serious problem right now in Columbus, Ohio, and hopefully this will be tapering off as we are vaccinating a lot of the at-risk people in those neighborhoods, and hopefully this is a warning sign for everybody. Again, measles is not a benign disease. Just some basic data straight from the CDC. 1 in 5 unvaccinated people get hospitalized. We saw more than 1 in 3 in this smallest group. In kids, 1 in 20 get pneumonia, and they can die from that. 1 in 1,000 can get encephalitis. And again, the mortality is 1 to 3 of every 1,000 children will unfortunately die. The complications in pregnancy. It's a bad disease that can easily be controlled, and we've had controlled it for years with vaccination. Running out of time, so we'll quickly run through the last 2. Polio. This is a worldwide concern. This is 2022. Data, again, from January 4th, 2022 to January 3rd, 2023. There's a map of the world cases of polio. 2 countries still have endemic polio. But if you see over here, we had a case in the United States not too far from here in Rockland County of paralytic polio. And this is the concern. And you can see this is really concentrated in certain parts of Africa, certain parts of Asia. The likelihood of this spreading is always a concern. We've eradicated native polio from the United States. All of these cases are from people who are still getting the vaccine in a live attenuated form rather than getting the dead virus. So this is a concern if we don't have good vaccination in this country. And what are we doing about this? So there are a lot of really interesting studies going on with wastewater. And you can look at, in New York area, 101 positive samples. And this was all related to a large extent to that single case of paralytic polio that we had in a Rockland County resident. And you can see that many other, this slide's a busy slide, running out of time, so I won't go through it in detail, but we basically saw that all of the surrounding counties from Rockland County and Orange County, and even in Nassau County, we saw a case identified in the wastewater, no actual clinical cases. This is all, to a large extent, from one single identified case of paralytic polio. We don't know how many cases that were not identified might have occurred. Again, paralytic polio occurs 1 in 100, 1 in 200 cases of polio. So polio is a killer. Polio is a horrific disease. And We certainly don't want to see a resurgence of that, and the only way to prevent that is vaccination. And finally, the last of our lightning round is Ebola. There was, and we'll end off with a good news in that this epidemic is hopefully just about to end. There were 142 cases confirmed in Uganda, and there were 55 deaths. That's again a 1 in 3 chance of dying. That's a serious illness. And there are more deaths that we didn't definitively identify as having been due to Ebola, but clinically looked like Ebola, but the testing wasn't done. This included, unfortunately, tragically, 19 healthcare workers, 7 of whom died. Thank God, to this point in time where we are right now, on January 11th, this outbreak is hopefully going to be declared over tomorrow. So this is a critical showing or demonstration that we can control these cases before we see cases spreading outside of Uganda. And they did some really great public health work, and they developed a vaccine for this specific strain of Ebola. The vaccine that we had previously for the other strains, there are 6 different strains of Ebola. So the vaccine that we had developed for the other strain of Ebola that causes significant illness wouldn't work against the Uganda strain. So this is just a great example where public health really can control something, and with technology and vaccination, we can do a better job. So I leave you all of the diseases that we talked about tonight. Every single one can be prevented. RSV, hopefully in the future, can be prevented with vaccination. So when they come to pick you up from the desert island, you're going to have to hopefully show a vaccination card if you want to get back on that cruise ship, because this is really the way to keep everybody on that cruise ship, everybody on the cruise ship called Earth, safe. And I thank you for listening, and I look forward to Dr. Heisig's presentation and to answer some questions after his presentation. Thank you very much.
Thank you so much, Dr. Glatt. Just gonna stop that sharing. And Dr. Heisig, you can go ahead and share your screen when you're ready. Just as a reminder, if you have any questions that you've thought of and you don't want to lose, please feel free to pop them into chat. We will definitely address them. I am going to pop into while we're getting those slides up. Wow, he's fast. Thanks, Dr. Heisig. I just wanted to also let you guys know to bookmark this page I'm going to put in chat. It's our upcoming events page. So if you're interested in more events, you can take a look at what's going on and join us. And we are also recording this event, and it will be, I'm putting in our recorded events page as well. It'll be there and on our YouTube channel. So thanks for getting that up so fast, Dr. Heisig. I will turn it over to you.
Thank you, Amanda. Are you seeing it as the slideshow?
I am. It's perfect.
Very good. And I apologize, my camera's not working well, so you can't see me. So pretend I look just like Dr. Glatt, even though I am significantly less well-dressed and significantly less distinguished. We'll just pretend. After that excellent presentation, I want to give you just a few minutes about PACE. Now, I have practiced for 40 years. This is my 40th anniversary, and I really didn't learn about PACE or understand about PACE until about 3, 4, 5 years ago. And it really is an amazing program for our multiply comorbid, frail elderly. And as an internist and a subspecialist gastroenterologist who practiced in academic medicine, in private practice, and did a variety of other things in my career, this has been one of my high points, because I think we do some great things for our senior population. PACE stands for the Program of All-Inclusive Care for the Elderly. And it basically started in early 1970s, late 1960s as the On-Look program in San Francisco. The Chinese were understanding that their elders who they honored were not getting the care as the extended family became nuclear. And so the community banded together to take care of older folks. This actually spread as a concept, and there were trials at the federal level in the early 1980s. And On-Look actually has become the first PACE program and still exists. With the Balanced Budget Act of 1997, PACE became an established insurance product and an established program. And the National PACE Association was formed in 1994. There are now over 135 PACE programs in the United States, and there are 9 in New York State alone. We're in Onondaga County. There's one in Monroe County, Cattaraugus County. There's Niagara and Erie counties. There is portions of the Albany, Schenectady, Rensselaer area, and Bronx, Kings, and New York, Richmond, and Queens, Suffolk, and Nassau. So there are programs across the state. We are probably one of the best represented states for this program. We are a combination of Medicaid and Medicare funding, as well as private funding. Most PACE programs are about 60% Medicaid and about 40% Medicare and some private funding. And what it creates is a unique insurance product that covers all of the care of its participants, including primary care, consultation, medications, hospitalization, skilled nursing care, durable medical equipment, and ancillary services. We take care of all Part A, Part B, and Part D Medicare care, and we provide direct primary care. As a result, okay, I'm the medical director of an insurance company, and I'm the medical director of a sizable primary care practice. So I can cut toenails and dress a wound and listen to somebody's lungs and prescribe medications, and then a few minutes later be discussing the need for an MRI and approving it through our insurance company so that it gets taken care of in an efficacious fashion. It's a wonderful combination. We take care of patients who are 55 years and older, and that is the National PACE Association rules. That's how the government has set this up. Because we are basically Medicaid funded by about 60%, those patients live in our county or zip code that is covered by the PACE organization. You have to have a UAS score of 5 or greater. And for those who don't know that or are not familiar with that, it's basically a designation that you would support skilled nursing care, that you have a need. Therefore, if you're a 55-year-old marathon runner, you're probably not going to qualify for PACE. If you're a 55-year-old person who does need medical assistance and nursing assistance, you're probably going to qualify. You also have to have a residence. Although PACE itself cannot provide a residence, we're often affiliated with organizations that can provide housing, and therefore we help out in that. And it is our community-based goal of aging in place. So I sometimes tease people and say, we are the anti-nursing home. Our goal is to really keep you out of a nursing home, keep you in your own home, keep you in senior housing, keep you in a place outside of a nursing home. Although as PACE programs are set up, we will cover nursing home care if that's necessary. We cover the whole bill. We are structured as a team approach. We have a team leader, often an advanced care or advanced educated nurse who coordinates the interdisciplinary team. We have primary care providers, nurse practitioners, physicians, internists, family practitioners. I'm an internist. Okay. We have clinic nurses, home care nurses, rehabilitation, which includes occupational therapy, physical therapy. We provide social services. We have nutritional support with registered dietitians. We have trained recreational therapists who help coordinate communication and provide recreational therapy. And we actually have transportation. So as part of the medical director aspect of my job, I have a fleet of buses under a transportation specialist who brings my patients to me to see me in the office and brings my patients to various subspecialty appointments as is necessary. And that's coordinated as well and paid for by PACE. So we all work together and we provide a comprehensive care plan for the frail elder patient. And those people specifically are trying to keep their community residents for as long as possible. People that could live at home if they could get somebody to help them shower at home, help them take their medications, maybe help them get dressed, maybe do wound care, and then come into a very structured program in our centers. In fact, we have people who could live at home and do live at home because we take them during the day so family can go out and work and do other things, much as the en look tradition originally was. We are a primary care provider. We provide ancillary services, and we are the insurance company. So it is very nice. They don't have to worry about paying the bill. We take care of that. Why do I want to educate my colleagues in the ACP? Well, again, I've done many, many things in my practice, and it is obvious that there are patients you can get through very quickly in your day, and then there are patients that end up stopping you. Some of those patients stop you because they're favorites and you give them a little extra attention maybe, but there's some patients that are very, very intense need. And so you find yourself filling out the paperwork for this durable medical equipment and, updating this most and answering multiple family questions because mom is just not doing well. And should she live here and can she live there and so forth and so on. And so those patients are very, very labor intensive. And sometimes those patients are actually best served by a team that can do that whole thing comprehensively rather than you as a primary practitioner trying to get all these things done from your office when you also have multiple other patients who need your time. The second thing actually is a bit of a selfish thing. We're all competing for staff and salaries, and I wanted to point out that for me, as I said, I've done multiple things. I started out as an internist managing a trauma center emergency department back before emergency medicine was as cool as it is today. I've been academic, I've been private practice, I've done a variety of things in a variety of settings. And for me, this is a very nice work-life balance. I'm busy, I'm very busy, but I have the ability to see patients on my terms. If it takes me 10 minutes, fine. If it takes me 20 minutes, fine. If it takes me an hour, fine. I'm not fee for service. I'm not quota driven. As I tell all of my staff, all of my providers, we are quality based. We are not quantity based. We make our decisions based on what is good for the patient, what is good for the system, and not what is time based and simply based on cost. So in short, we are a program of all-inclusive care for the elderly, and we do take care of the elderly comorbid patients who need multiple services. We are team-based. The clinical aspects are led very firmly by providers, by physicians, and our assistants as nurse practitioners and our nursing staff. And I think we do a great job on taking care of this type of complicated patient. And as Dr. Glatt is willing to answer questions for his excellent talk, I stand by for questions for PACE. Amanda, back to you.
Perfect. Thank you so much, Dr. Heisig. That was really interesting. Lot of information, clinical information, even some well-being with talk with work-life balance and some great resources. Actually, I have a 99.5-year-old grandmother. I say half because it counts. So, and she is aging in place. We're some of her primary caregivers. So the PACE program really piqued my interest. That was wonderful. And I have friends with new infants, so the RSV was really helpful. So hopefully it helped all of you as well. Just waiting for some questions to come in. As we do, I'll kind of break the ice. It's maybe not from a physician perspective, but Dr. Heisig, what's the best way to refer a patient to a PACE program if you feel like somebody might be a good fit for that?
That's an excellent question. First off, you have to find if there's a PACE program that serves your community. And again, we're basically county or zip code based. So if you have a PACE program in your county, you'll find on the internet all of the various numbers and locations. The National PACE Association advertises, and you can make those phone calls. In every PACE program, it is required that there is a very rigorous enrollment and marketing department. It's very ethical, knows all the legalities, and really goes over whether it's effective or appropriate for you. And so once you make that phone call, they'll often give you all the information you need, brochures, documents, et cetera, to see if you or your loved one, is right for PACE.
Great, thank you. And I did just Google, I'm in the Albany area for, I just Googled PACE program in Albany, and it's pretty simple to find. So I'll try to throw some links in. What other questions do we have out there?
I have a question for Dr. Glatt, if you don't mind.
Don't mind at all.
Dr. Glatt, I share your concerns that COVID is going to be part of our regular life. Do you anticipate for the near-term future an annual COVID vaccination and an annual flu vaccination as part of what we're going to be seeing for the next 5-10 years?
So that's a great question. I wish I knew a great answer. I think certainly it's possible. I think the betting person would say that we're probably going to need to get some sort of a booster on a regular basis if COVID stays around. I don't know if it will be an annual shot. I do think that we need a lot more information before we start just recommending that everybody get an annual shot, because first of all, the nature of the variants, it's unclear how much more benefit somebody would get from getting a fourth or fifth additional booster from the same boosters that they had previously, how much benefit that would give you against something like XBB or any of the future variants. The good news is that people aren't really getting very, very, very sick, even if they've only gotten just one booster, even if they haven't gotten the bivalent booster. And what I might think could happen is that only people at the highest risk standing, so maybe people above the age of 75, maybe people with 50 or 60 plus significant underlying comorbid conditions, might need to get each year especially engineered, similar to the bivalent, to catch the more recent strains. And only that population needs to get it, because the rest of us hopefully would still be protected from having had either natural immunity plus vaccination or just a booster and the regular series of primary vaccinations. So I think it's unclear at this point in time whether we'll really need to say the rest of the population, to all of the population, you need to get an annual shot. But it's a possibility. It is a possibility.
Thank you. Perfect. So we do have some questions. I saw Dr. Anandu. I will say, I did pop I just Googled, what did we do without Google? But I just Googled, and I popped a link in chat for a list of the PACE programs in New York. But Dr. Anandu, did you have a question?
So actually, I was going to see if there was any kind of resources that Dr. Heisig could share with us about how to look for resources in our area. I appreciate the link in the chat.
Right, and I would also just, you can look up National PACE Association, and the National PACE Association has a non-member link that opens you up to state, federal, whatever. If you've got somebody in Florida, somebody in Arizona, someplace else in the country, and you're looking to see if a loved one might have access to one, that's there.
Perfect. I just popped that in the chat. There's a PACE Finder program. That's awesome. Okay, so that link is in the chat as well. We do have another question that came in that says, should we be offering polio boosters to our patients?
Also a very good question. So at this point in time, there was a recommendation, which I personally strongly disagreed with, that people in healthcare should consider getting a booster dose if they lived in one of the areas where there was an expectation or a likelihood that you would encounter a patient with polio. So that recommendation was not based upon any hard data. I think it was a little bit of a, what do we do, type of an approach rather than a science-driven approach. I'm not aware, and I've asked this to hundreds of infectious disease doctors, as well as doing multiple searches. I can't find a single case of polio occurring in somebody who's been fully vaccinated against polio, meaning they got their appropriate doses of polio vaccine. So I do not think at this point in time there's any reason for a fully vaccinated person to go get an additional polio vaccine dose. However, people that have not been fully vaccinated, I strongly urge them to go get an additional dose, especially if they know that they're in an area where the wastewater has demonstrated that there is polio around. But that original recommendation, which would have required, if we had followed that recommendation, every single person working in a hospital in New York City and in many of the surrounding suburbs and counties would have been required to get a booster shot, which made no sense whatsoever from a medical perspective.
Thank you, Dr. Glatt. We have another one. Is there, keep them coming, everybody. I like this. Is there a reliable blood test to check for antibodies in patients that aren't, sorry, I'll say this again. Is there a reliable blood test to check for antibodies in patients that aren't sure if they were vaccinated for polio?
So there really isn't. And what I would recommend is, depending on your age, if you are born probably before the year 2000, then you almost certainly have been vaccinated. If you went to school, if you weren't living in the United States, it would be different. If you went to school in the United States, almost all the schools required polio vaccination as a condition for entering school. So there's an excellent chance that you would have been fully vaccinated. And the anti-vaccination movement was always around, but it didn't have the strength that unfortunately has today. And there was no social media, which may be the single most destructive anti-vaccination force that there is, because I'd hate to think what would have happened in social media in the 1920s and 30s and 40s. Would we have eradicated smallpox, which is the only disease still known to mankind that's been eradicated, and it only is eradicated because of vaccination, or inoculation. And the people that are born after 2000, the pediatricians should have accurate records, and there are registries. So I think most people should be able to find out if they've been vaccinated or not. And if somebody has not been vaccinated, then yes, I would recommend, if there's any doubt, if they really have a doubt, as opposed to they just don't know for certain. But if they either were raised in a family that didn't vaccinate, or they come from a different part of the world where vaccines may or may not have been available to them, so then in that situation, get yourself vaccinated. There really isn't a good blood test that you can get to demonstrate immunization.
If anybody would like to unmute, you are, if you don't have time to type or aren't able to type, please feel free to unmute yourselves to ask a question. And also I'll keep taking them in chat, but I'll pause here.
Hi, it's John Altus. I'm a physician that actually is at Dr. Glatt's hospital, and always a privilege and a pleasure to hear him speak. My question for Dr. Glatt is that often patients will come in where they'll have antibodies done that show against COVID, and they'll go ahead and make the claim they don't need to get a vaccine because of their antibodies. Is there ever a time where COVID antibodies can be used clinically to have a patient not get an appropriate vaccination or booster for COVID?
It's great to see you here and hear you, John. Always a pleasure. So I would say that in my professional experience, I can't think of a single patient where knowing their vaccination, knowing their antibody status has made any change in the clinical scenario. I think that at this point in time, a very significant population of the United States, percentage of the population of the United States, has had natural COVID and has a certain level of immunity. That level of immunity is beneficial, but it's certainly not 100% protective. The best immunity has been shown in studies to really be vaccination plus natural immunity, which again tells you that the vaccines aren't perfect. The greatness of this vaccine, and this was the biggest mistake from a public health point of view that we did, was not to express the limitations of the vaccine, as excited as we were to get it. I remember how excited I was when I did get the vaccine, but we should have better done a job telling the public that this will not be perfect, but boy, oh boy, there's an unbelievably good chance that you're not going to die from COVID. And that has been borne true. But unfortunately, we should have taught people, and maybe we just didn't know enough, but once we did know enough, the message should have been, you may get COVID, but you're not going to die from COVID. And that's the overwhelming message that we have. And I think that really is the message that we've had really with flu vaccine. People that got flu vaccination still got the flu, but the vast, vast majority of them didn't get very serious illness. There always are going to be exceptions. There are patients who've been fully vaccinated and unfortunately died of COVID. There are patients that are vaccinated annually for flu and then will die of flu, but those cases are relatively few and far between. And that's because these vaccines do work very well in preventing serious illness. So I don't personally ever order antibody levels for COVID. At this point in time, I'm not sure what they would show. Half the time originally, I remember after the vaccine came out, a lot of people were dying to see if they had immunity from the vaccine, and they ordered the wrong antibody, and they got back no antibody, and I would get only from doctors. I would say 100 calls a week from doctors telling me, I did an antibody test and it didn't show I have antibodies. What should I do? And I said, well, you didn't do the right antibody test. And you have to do it for the spike antibody for the vaccine. And there are other antibodies that aren't present in the vaccine that you can demonstrate that somebody had natural COVID. But again, I don't see much of a clinical reason to do so outside of a study setting.
Thank you. And another one come in through the chat. Thank you so much, Dr. Altus. It says, are we returning people too soon to regular activities following acute COVID-19? Do we need 2 negative rapid COVID-19 tests prior to returning back to work or school at day 10?
Okay, also great question. So I'll tell you what the data are, and then we have to decide how we want to live our lives. The 5 days number that everybody throws out there is a made up number. The 10 days was a made up number. The 15 days, 14 days, they're all made up numbers. Statistics work in generalities. They're not perfect for any individual patient. So I can reliably say that a non-severely immunocompromised person will probably have a 98, 99% chance that they won't be shedding active live virus 15 days after they had COVID. I can make that pretty definitively. I can't make that statement after 5 days. I can't make that statement after 10 days. What I can say is that the vast majority of people after 10 days, probably in the order of 90 to 95%, won't be shedding contagious virus 10 days afterwards, assuming that they're not severely immunocompromised. At 5 days, you can probably say that somewhere between 80 and 90% of patients, possibly, a lot of the data is with older strains, it's not with the newer strains, will possibly not be shedding active live virus. That doesn't always translate to whether they're contagious or not. So what we do is recommend, from a common sense point of view, is who are you going to be around in those additional days? So 5 days certainly I think is a minimum number that we would isolate somebody. I don't think I would remove somebody from isolation if they were within 5 days of having onset of symptoms. Yes, a percentage of them will not be contagious, and a percentage of them will be contagious. And I have no way of really determining which one is correct. We really don't have good utility with the antigen tests. And there are people that can be negative, 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 and then turn positive. So does that mean that they weren't contagious and now they are contagious? We just don't know. So as a rule of thumb, I tell people for 5 days after day 0, so on day 6, you are no longer considered as contagious as you were previously. And if you're a healthcare worker and you need to be at your job, so we allow them to come back wearing an N95. If we had infinite resources, I would tell them to stay home until day 10. But we have staffing issues and concerns, so we allow these people to come back wearing an N95 at all times. They're not allowed to socialize with anybody else in the break room. They can't go and be around any other staff members without wearing their N95. If they weren't in healthcare, they're working at a McDonald's, they're working at a bank, probably the safest thing for their coworkers is to stay home till day 10. And then you'll pick up 90, 95% of them that will no longer be contagious. But we don't really know who is and who isn't. Obviously, if they're still having significant fevers and symptoms, I would be a little bit more concerned. But it's not clear that that really correlates. Having a cough certainly doesn't correlate with being contagious. The cough may last for weeks, and that may or may not have anything to do with contagiousness. So for a lot of this, we have to be humble and say we really don't know. And I use 5 and 10 days as guidelines. And I tell people that if you're around somebody who's sick, if you're around an elderly parent, grandparent, great-grandparent, and you had COVID within the last 10 days, you probably shouldn't be around that person. If you have to be around them, you're a caregiver for them. You're the child preparing dinner for them. You're taking care of that elderly parent or grandparent. So then you should wear an N95 when you're around them in the first 10 days. That's my best advice.
With the question asker, thank you so much for this clarification, and thank you, Dr. Glatt. That was helpful. Let's see. I think we have another one that came in. Some places aren't letting patients back to work until they have a negative COVID test. I thought patients should not be retesting after an infection.
That is correct. I don't recommend retesting after you've had COVID. I wouldn't know what to do with the answer. The PCR can be positive for a variable period of time, and nobody's ever shown that a positive PCR on day 27 in any way correlates with contagiousness. So everybody's familiar with a single case patient where they were positive and were able to show live virus in that very highly significantly immunocompromised patient for several months. That's the exception. That's not the rule. And for the vast majority of people, by day 15, almost all people are no longer considered capable of transmitting infection. Again, if your patient is significantly immunocompromised, maybe be a little bit more careful. We use 20 days in that situation. But I don't think there's a role at the current time for doing antigen testing and saying to a negative antigen test, that means that you're no longer contagious, or PCR that's positive says that you are contagious. I think that's just incorrect. Scientifically, it's not valid. I mean, everybody's probably familiar. About 6 months ago, David Ho, one of the gurus of HIV research and COVID research, so he had rebound after he had COVID. And he did some very elegant studies on himself. You're David Ho, you can do that. And he basically did a daily PCR and viral studies on himself. And he was positive, negative, positive. So what does that tell you? It tells you that we really don't know as much as we would like, and we have to use generalizations. And again, 5 days, 10 days, I think are reasonable general guidelines, not 100% fact-based. And again, I would say it's a nuanced approach. If you're living with somebody who's very immunocompromised, can't afford to take the chance that they get COVID, don't be around them for 10 days. That's the simple answer.
Thank you so much that we're still learning. Can't believe it's been like 3 years in and there's so much we're still learning about this. Thank you. Any other questions out there? Please feel free to use chat or unmute yourselves.
I have a question for Dr. Glatt, Dr. Heisig calling. So, we live in a very highly regulated state. And for those of us who take care of the elderly on a regular basis, the regulations are still pretty intense with regard to COVID and risk mitigation. We know that the federal government has maintained the COVID emergency in part because releasing it would make create a significant impact on insurance coverage for a huge swath of the population. At some point, however, mask wearing is becoming challenging in hospitals, in nursing homes, in elder care facilities. As the cases dissipate, probably as spring comes by, do you think we can start to lessen our social isolation a little bit and move about more freely?
So I think so. I think it's a very important point that you're making, Dr. Heisig. And thank you again for your wonderful presentation. I think that in the beginning, in March, April, May of 2020, when we were seeing people dying left and right, we were seeing physicians, nurses dying from this illness. We were seeing huge populations decimated, especially the nursing home population, decimated from this. So we had to make broad strokes and say, everybody mask, everybody stay away, nothing indoors. I think we now, thank God, with vaccination, with some of the medications that we have to treat, with a better understanding of how to treat seriously ill patients, I think that we can take a very nuanced approach. And I personally, I don't want to sound like a hypocrite. In the hospital, we have certain regulations. I don't follow those regulations outside the hospital for my own personal life. I do go indoors, and I do not wear a mask when I'm indoors. I try to tell people, if you're sick, please don't go indoors. Please don't be around other people if you're sick. Take a certain level of responsibility. I know a lot of people don't do that. They say, well, it's just COVID. It's just the flu. I think that's wrong. And I think each of us has to take our own level of risk taking that they're willing to take and make decisions based upon that. I respect somebody that wears a mask indoors. I respect somebody that says, please stand a little bit back. I respect somebody that says, no, I'm not going to wear a mask indoors, and I'm willing to take my chances. I'm fully vaccinated. I got the bivalent vaccine. I'm aware that if I get symptoms, I'm going to take Paxlovid. I'll take therapy right away, and they're willing to take a chance. And I think that's the point that we've gotten to in society. Whether we'll get that way in the hospitals, I don't know. I think the hospitals always are extremely conservative in terms of infection control practices. And being the hospital epidemiologist, I have to agree with that because there's just too many risks involved. If we have significant outbreaks in the hospital, we can knock off all the nurses in the ICU. We could, unfortunately, dealing with very, very sick patients in the ICU, knock off all the patients in the ICU. So we have to be extremely careful in a hospital setting, much, much more so than we have to at a baseball game or at a restaurant or a restaurant or a store.
Thank you, sir.
So thank you so much for joining us. The recording will be posted, and I usually send out an email to all attendees as well. But I will pass it over Dr. Glatt and then Dr. Heisig, if you'd like to leave us with any parting thoughts, that would be appreciated.
Sure. So I thank you all for taking out time from your very busy schedules. And I really want to thank the ACP and Amanda for putting these types of events together. I mean, I always love the title, Multiple Small Feedings, because that's really what we as physicians always have to have. I think that education is a lifelong event, and ACP does a wonderful job, both with their journals as well as with their advocacy on behalf of internists. And it's an honor and a pleasure to be part of the ACP.
I would echo Dr. Glatt's words. It has been an honor and a pleasure to be a member of the ACP for many, many years. And with regard to this particular career turn I've made, it has been a wonderful chance to take great care of a lot of patients who really need medical care and really benefit from medical care, as well as a comprehensive approach. And for those physicians who have railed against the insurance companies for years and seen them as the enemy, sometimes the best way to take care of the enemy is to eat them. And that's what we've done. We now control the insurance companies. We are the insurance companies, and we really can be more efficient and effective. And if we run into a problem, we have only ourselves to blame. So I would consider PACE for those of you who have it in your community and patients who might really benefit from this type of team approach. So thank you, Amanda. Thank you, Isaiah.